This exercise is basically to evaluate a new patient, whether it be the ER. In this case, he's going to be already in the room. And what I want to tell you, basically, you can do a full history and physical, and your orders within 30 minutes, as long as the patient's not critical. It'll take about an hour if it was an ICU patient. Of course, I already came in, knocked on the door. The patient's name is John Doe. I said, good morning to Mr. Doe. I explained to him who I am. I'm Dr. Suarez. I'm here to do your physical exam. The importance of it is very important because right now, to get this out of the way, this is going to lead us to the information that we need to treat you correctly and avoid any problems. Okay? Of course, you wash your hands, and now you're ready to. Now, always check the band. If he doesn't have an appropriate band, you call admitting, do not touch him. I don't care if he shows you an ID or his served in Iraq card, okay? So, very important. So check the band. Double check that you're doing it the right patient, okay? And after you do that, then you can start. The only time you call a patient by their first name is if they go out of their way and say, please call me by my first name. Okay, so don't be extra familiar with them. Do not say John. No, he's Mr. Doe. So Mr. Doe, I'm going to ask you a few questions if you don't mind. Always use a piece of paper, even though we have the EMR. In fact, take a quick look at the EMR system. The key thing to the physical exam is not to leave the room, because you're going to ask certain questions, and later on, as you're getting down the information, and that's why the rooms have computers now, and you want face-to-face time, not be on the computer and be constantly using your back to the patient. That gives a very bad feeling to the patient. Also, right now, he's sitting up, and he's above me, which is a good position. Once he lays down and I'm above him, that's a very intimidating posture. So try to avoid that as much as possible, okay? And if not, make sure he's sitting up in bed as much as at least 45 degrees, okay? Any questions so far? All right, so the basics is, can you tell me your age again?
54.
54-year-old, white male. And for what reason did they bring you to the hospital?
About a week ago, I was having conductive cough. I was a bit short of breath.
Okay, and this is all new?
Yep.
Did it ever happen before?
No.
Any recent colds or anything like that?
Not that I know of.
Do you smoke?
I do smoke.
How much do you smoke?
I smoke about a pack of cigarettes.
How long have you been smoking for?
20 years.
Okay. Do you have any allergies or anything like that? No known allergies, all right? You ever been to the hospital before?
No.
Okay. No surgeries, nothing like that?
No, nothing.
No other respiratory problems before? Asthma as a child, allergies or anything like that?
I've had a couple of upper respiratory tract infections.
Okay.
But
So
nothing.
regular colds?
Yeah.
Okay. What kind of work do you do?
I'm a PA.
A PA. Okay. What kind of doctor?
Cardiologist.
For a cardiologist? Okay, good. No work exposure or anything like that would upset you breathing wise?
No.
The shortness of breath come on really quick, or was it on gradually?
I came on gradually.
Okay. The phlegm that you're bringing up, what color is it?
It's been clear, but I've also noticed it having maybe a little bit of
Yellow?
or greenish.
No blood?
No, no blood.
Okay. That is what's called is a pertinent negative. So you're going to write pertinent positives and pertinent negatives. You don't need a review system. The review system goes into the HPI. The HPI is extremely important to do it. 80 to 90% of all our diagnoses are in the HPI. So if I don't have a good information by that time, we're lost, and we're going to be lost for the rest of the case. So it's important to go back and make sure you have a good diagnosis. By this time, since he's in the room already, we may have some basic labs, a chest X-ray or not. It's fine to be looking at that because it kind of cones you down, but do not be limited by that, okay? Still have a wide open diagnostic criteria. So no blood, no smoking. Have you had your regular vaccines?
I have.
All vaccines, okay. How about pneumonia and flu shots?
Yeah, I got this.
Okay.
Wait, sorry, no, I didn't. I got one of them, but I can't remember which one I got.
Is it what? Okay, so probably the flu. We don't know about the pneumovax. Okay. You said you had no allergies, no surgeries, no past medical history. Any problems with your legs? Any other complaints?
You know what? Like I had a fever.
Fever? Okay, how high?
About 101.
So chills?
Yep.
Your teeth shake?
No, I didn't get that bad, but
Okay.
I did have some cold sweats.
Sweats, okay.
And I also
So you know
noticed-
your PPD status, you know the test they do on the skin for tuberculosis?
Yeah, it was negative.
Negative.
Get it
How
done
long
for-
ago?
I get it done every year.
Every year, okay. Okay.
I also noticed that when I'm walking upstairs or if I'm take deep breaths, I feel
Little
very pain.
Okay, but is it sharp or dull?
It's a sharp pain.
Sharp pain, okay. One-sided or throughout the chest?
It's throughout the chest.
Throughout the chest, okay. So you couldn't pinpoint it with one finger?
No.
Okay. Fatigue, muscle aches?
Just regular. It's not really, not significant.
Okay. All right. Okay, you take any medications?
Yes.
What are they?
Few for high blood pressure.
Okay, you know the name?
No, I don't.
Okay. Is anybody in the can you bring the bottles in when they come to visit you?
Yes.
Okay. That's the only thing you take something for blood pressure?
Yeah, just blood
One
pressure.
pill or 2 pills?
It's one pill.
Okay. Anything else you want to tell me that I haven't asked you or anything like that?
Just besides this cough and feel a bit of short of breath.
Okay. What about smoking at the workplace or at the house? You're exposed to passive smoking at all?
Oh, well, I smoke a pack of cigarettes.
Yeah. Besides that, though, do you smoke with other smokers?
Yeah.
Okay.
And social smoking.
What was your last X-ray?
My last X-ray was when they admitted me to the hospital.
So before that, no X-rays? Okay. So no old records or anything like that?
No.
Okay, good. All right. So if I'm going to ask you to we're going to do a quick physical exam. Of course, he should be in a gown. Luckily, he's not. So just ask him to lay down. And then by this time, if he's up here by now, he's already had vital signs done, etc. But it's okay for you to recheck him. Okay. Blood pressure. Start from the top to the bottom. Okay. Once again, it's a little bit imposing, so don't make it extra long. So what I'm gonna do is I'm just gonna check for lymph nodes. Put your head back for me. Thank you. Take a look at the eyes. Who's got a pen light? Okay. And at this time, you may want to bring down the. Now, if we're looking for icterus, you definitely want to do it under sunlight. Okay. And at the same time, hold his head and say, okay, follow this light for me. So we're doing part of the neurological exam. Look at the nares. Open your mouth for me. Give me a big eye. Okay. Flex his neck. Looking for flexion. There's no meningismus. Okay. All right. You can take the otoscope. Take a quick look if you want. Same thing with the ophthalmoscope. It's once again the room dark. That should be enough to have him dilated. If he really needs one, which right now the only reason to do a dilated scope would be because he has a history of hypertension. You want to see AB making and see exactly if you can stage him. No neoproliferative type of things. Okay, stethoscope, please. Remember, he has no shirt at this time, or at least open in the back. So we're going to listen. Of course, your 4 areas. Listen to the neck for any bruise. Okay, can you sit up for me for a second? Take some real deep breaths through your mouth for me. Through your mouth, through your mouth. If he doesn't know how to do that, you do this. The only way you're going to be able to auscultate appropriately is with mouth flows. Otherwise, you can't. And even then, we're only going to be able to listen to about 20 to 30% of the lung. Okay? I hear nothing abnormal, so I'm going to percuss him anyway. Also, notice that he didn't get pain when he took a deep breath. And the fact
should have hurt me.
Okay, but and the thing is that sharp pain will go for pleuritic chest pain, pericarditis. I hear no rub. I don't hear an S4. I don't hear an S3. So we did that. This could be a focused physical exam or basically the whole physical exam. Now we're going to auscultate the abdomen first. I don't have it in my ears yet. Okay. After you auscultate, you palpate. Go from one quadrant to the other. Okay. You're looking for rebound tenderness. You can do a Murphy sign, etc. Then you move down to the legs. The first thing you want to do is check for edema. If there's no edema, the patient cannot be fluid overloaded, basically. Okay. If he has edema, you start taking a CHF. Also, when we did his head, you should have looked to see if there's any JVD. He should be more at 45-degree angle than he is at now. Okay, and anything above the jaw is positive for an elevated jugular venous pressure. Okay, and if you want, once again, we're doing the focus, but let's see, let's check the back. This will also be positive in meningitis. Okay, and have we missed anything? Right? So now the key thing to do now is, I'm going to go like this, and I'm going to sit here, or you're going to go to the computer and say, I'm going to take 5 minutes to put this information in. And that's the perfect time to say, by the way, tell me anything else you want to talk about, because he may say something important. Like I didn't ask him about birds exposures, or
Sure.
Even though he's a PA, he may be a bird fancier, he may be a taxidermist, which would be important as far as. But now, our differential diagnosis is he has possibly pneumonia, chronic bronchitis, mucopurulent bronchitis. If he's admitted to the hospital, most likely he has pneumonia. So we're going to do a calcitonin level, check the chest x-ray, check the white count, do blood cultures, look for the appropriate antibiotics. We already have orders in place. He could be in a regular room, his vital signs are stable. Okay. If you have to do the blood, when you do your blood pressure, it's 140/80. He's a hard stick. Bring up the cuff up to about 120. You have arterial coming in, venous coming in, no arterial coming out. So the veins are going to be as big as possible. Also, if he has pneumonia, BUN creatinine. He's not a high risk for CURB 65, so things like that. Do we hydrate him? Yes. Either orally, because you want the phlegm to break up. Give him aerosol therapy for any type of bronchospasm. So this becomes automatic, knee jerk. So, like I said, let's say I take my little notes, and I'm going to work on the computer. I'm going to tell them, feel free to tell me anything while I'm working on this that I forgot to ask you. And then as I go through the computer, there's going to be, I don't care who you are, you're going to forget to have asked something. So that's why you don't go anywhere else, because you're not going to come back, or you're going to forget to ask him. While I'm here, all of a sudden, he may say something important, I'm going to ask him some more questions. Or I may say, well, geez, I forgot to ask him about this. Is he married? Does he have any kids? Are the kids sick? Do they go to a community health center? That type of stuff, because it could just be a virus. Okay? And if you have lab works already, you can discuss the case with him. It's very important for him to know what's going to be done to him and what's to be expected. Okay, when you're going to see him next, who the primary physician is, answer any possible questions. His dietary habits. He may not like the food, so get dietary to be evaluated. So he may have a religious objection to certain things, so get dietary involved. So now we did the H&P, and now we can just write the orders. The orders are obvious. Regular room, he doesn't need anything more intense than that. He doesn't need an IV to hydrate right now, because unless he has an elevated BUN or creatinine, so a HEP block. Just have venous access. Try to give him a once-a-day antibiotic in his case, if we're looking at a community-acquired pneumonia, which we are, or non-healthcare acquired pneumonia. Levaquin would be a great drug. Covers pneumococcus, all the atypicals, which would be high on him, even though he's in his 50s. Good looking for 50. Okay, but that's how we talked about picking antibiotics in another lecture. So that's how you would do that here. Also, you want a chest X-ray, a PA and lateral, a CBC. You want to run down his diet, no known allergies. Okay, activity level, ad lib, bathroom privileges. You want him walking around as much as possible. He doesn't qualify for DVT prophylaxis. Okay, so he's moving around. So ask him. What I always try to do is tell the patient, eat your meals outside the bed. So in other words, you want him to move around. Also, the fact that he doesn't have an IV and just a HEP block, that gives him the ability to move around. And you also want to know by tomorrow is your shortness of breath getting better, especially when you walk? You need a blood gas. Is he hypoxic? If I get a SAT, that's a poor man's blood gas, but still I want to see what's going on with his CO2, because if he's hyperventilating, that's actually a worse prognosis if he has a pneumonia. Okay? Remember your SIRS criteria. So we're basically done after doing your EMR. You've done your orders. This is not a real complicated case, but your last thing is talk to the nurse, go over your orders, make sure she understands them, and a sed rate, a CRP, a procalcitonin depending on the pneumonia, sputum for gram stain and CNS. These are basics, automatic. They should be knee reflexes. Okay? We're good?
Yep.
Any questions? Okay, good.